Any health-related information on the following show provides general information only. Content presented on any show, by any host, or by any guest should not be substituted for a doctor's advice. Always consult your physician before you begin any new diet, exercise, or training program. And thank you for listening to the Whole Care Network.
Welcome to Healing Ties on the Whole Care Network. On Healing Ties, we're creating a life to love after caregiving ends by sharing stories and resources and being with awesome people like you. Now that caregiving has ended, let the Healing Ties begin. Here's your host, Chris McClellan, the Bowtie Guy.
Well, greetings everyone. It is Chris McClellan, the Bowtie Guy, for another episode of Healing Ties. Actually, it is our 5th episode of Candid Conversations About Care with Amanda Singleton from Singleton Legal.
Thank you for having me, Chris.
And it's great to see you again.
Great to see you as well.
You know, as we've gone through the last 4 weeks, now that we're entering our 5th week, there's been a couple of themes. We've used that 4-letter word called plan, and how that seems to have gripped all of our conversations. And then, today we're going to talk a little bit about navigating healthcare. And again, part of the themes that we've gone through the last 4 weeks is that concept of a team, how we create a team. We can't do it all ourselves as caregivers, even though we think our caregiving cape can just snap and make everything okay. But today we're going to talk about on the healthcare side. But first of all, remind our listeners about you and your background.
My name is Amanda Singleton. I am a multi-time family caregiver and attorney in St. Petersburg, Florida. You can find me at the Caregiver Lawyer at Singleton Legal, www.singletonlegal.com. And part of our mission in doing this podcast is to give people resources that they can plan to care for someone else or with someone else and to be cared for themselves someday, as so few of us are exempt from a critical illness, catastrophic situation, or just the gifts of nature in advancing years. And so part of my firm's mission is to advocate for caregivers and help them to be better advocates and to utilize their team. And so we've seen with lawyers and financial planners across these episodes how crucial it is to use professionals and rely on them to be the experts that they are. And a huge part of the experts in your caregiving life will be your physicians and how you communicate with medical providers, because they will help you advocate and they will be advocates for you. So we've brought Dr. Osman Ahmed here today to talk about navigating the healthcare system from a doctor's perspective. So, Dr. Ahmed, thank you for being here today.
Thank you.
Tell our listeners a little bit about your background and everything that you're doing to help caregivers.
Thank you. Good to be here with you. And I'm a family physician. I'm an epidemiologist, and currently I'm a medical director with WellMed. And really what I did, and I do still, is either take care of seniors, especially with medical illnesses, and make sure that they have good clinical and care management plans in order to help them either manage their illness or navigate the healthcare system.
That word came up again, Amanda, a plan. Creating a care plan. I often think that caregivers need a care plan for themselves as well. And as you have experienced in this vast network of medicine, and now this explosion of family caregivers, do you see a need for caregivers to have their own kind of care plan?
Well, I look at caregivers as part of the care team. I look at caregivers as being also advocate for the patient.
Yes.
And through this kind of dual role of being an extension of the patient wishes, they know a lot about the patient. So having said that, these caregivers should have or should build a plan with the treating physician, in addition to other members of the care team, that will enable them to detect any change of patient's condition, understand what illnesses they have, know what kind of benefits they have, healthcare benefits, and being able to maximize or help the patient maximize their own benefit plan, for example, in order to improve their care, in order to have better outcomes, in order to do a lot of good for the system. And I think our care system is very fragmented. So especially with people with chronic illnesses and elderly individuals, the need for that role and this person caregiving role is very important.
Really interesting point. And one part of the conversation that we wanted to talk about is where are the gaps in the healthcare system? And so you've already identified the fragments. And I can relate as a family caregiver, my frustrations in not having a conductor for the medical train. There was not one central place where information was shared and exchanged among the many physicians that were treating my mother through a very catastrophic illness. And I wondered, who is supposed to be doing this? It can't possibly be me. And it was such a game of telephone. Do you know the game, the children's game, where you whisper in somebody's ear and they hear the message and then they whisper it in someone else's ear, and by the time it gets to the last person in the line, you're not really sure what the original message was? And I felt that way as a caregiver. Our physicians, when I bring medical records and they read, or they receive a report from someone else, is that providing the full picture? And so let me ask you, what can we do to work with that fragmented system when we have sort of a multifaceted plan of treatment from providers of different specialties?
I think it's a very important point, Amanda, that you just mentioned. Healthcare system became so complex these days, and there are a lot of providers, a lot of different types of providers. And because of the complexities, and also because of the primary care doctors taking kind of a back seat, and instead of being really the coordinators, the managers, the glue in the system, because that's the way I look at them. I look at PCPs in general, primary care physicians,
yes,
at the glue that should have connected all the fragmented components of the system, if you will. But I think when I say we, the healthcare industry, through some mechanisms of reimbursement and otherwise, alienated a lot of the PCPs traditionally. And I think it's coming full circle now, but we alienated them to the extent that a lot of people don't want to be in this role, which they should be really the maestro. There should be a conductor.
Yes.
And the system now goes without a conductor. It's like it's really amazing, because when you look at every type of specialty, every type of physician taking care of the patient, they are kind of doing their thing, their part. So cardiologists take care of the heart, but doesn't take care of anything else. Endocrinologists take care of the endocrine system. Psychiatrists take care of the psyche, but really there's nobody that takes care of the whole patient. So what's happening with the healthcare industry these days, that there's this feeling of a void that should be filled by PCPs. Nationally, there are a lot of things happening at the level, particularly of CMS, to reward physicians based on taking charge of and doing this role. Reward them for better outcomes, reward them for better use of the scarce resources, on advancing actually the sharing of information amongst themselves and amongst other people. And as you remember, that the electronic health record, when it started very haphazardly too nationally.
Yes.
It's like we have like hundreds, maybe thousands now of vendors, and they don't talk to each other. So the data sharing and information is missing.
Yes.
And nobody wanted to drive that, take care of it, because it's a lot of investment financially.
Right.
So people have just switched from having a handwritten or transcribed medical record to having a digital medical record. But the intent was really to exchange information. So no information is being exchanged yet in the best way that the people envisioned, probably. We're trying to get around it by things like HIE, Health Information Exchange, or I'm trying to get around this by rewarding physicians to somehow figure out a way to exchange information. Especially CMS, like I said, is leading national efforts, either with the Medicare Advantage or just traditional Medicare, original Medicare, to enhance this process of information sharing. Because you ended up doing less testing, you ended up learning about what's happening to the patient. All the people that are, managing this patient, whether they're specialists or whether they are primary care physicians, they end up learning about each other. So you don't order a bunch of tests when they were done before.
Correct.
And you don't ask the patients to go to multiple places if they don't need to, especially if they have chronic illnesses, they are very sick, they don't have transportation.
Limited mobility.
And nobody really check on the psychosocial element of their illness. All these things are missing.
And it falls, in my perspective, to the caregiver. And they become the one, and they're the backbone. And I truly believe this is a bit broken, because a caregiver should not be identifying that medication contraindications may be the case in the pharmacy, which is the last line of it, may not catch it. Or that, it seems that we should do some testing, but everyone's kicking the can down the road. And that was certainly my experience as a caregiver. And I think, I read once the reference to the steely-eyed daughter who is terrifying to the front office staff at the medical providers, because you have to come in like gangbusters to get attention, because everybody is at the max with their patient load, and to get attention, unfortunately, in this world, the best way is to be a very squeaky wheel and to be persistent. But that gets exhausting, and to be made to feel that maybe you shouldn't be pushing it so much, and maybe you shouldn't be questioning it so much. But the thing is, we want the best possible outcome for a loved one who's undergoing any medical treatment. So we push and we persist that way. But is there a way for us to communicate with our medical providers what we feel is lacking in order to get a better treatment plan?
Definitely there is a role. There is a role for caregivers, and there is a role for patients themselves if they are capable of, managing, or they are empowered in a way to manage their own illness, either through information or through even the caregiver sometimes. Because a lot of people take, for example, medications, and they don't know why they're taking it. And I don't think a lot of physicians do a good job explaining how these medications work, and what may be, a disease that could be without any symptoms. And you take the medication, and then you get symptoms from the medicine. And then sometimes the person wants to stop taking them, and if they stop, they might get a complication or a consequence from stopping the medication. Right. So we don't do a good job educating the member, the patient. So as a result, I think caregivers are the ones that should be more empowered to manage these gaps in care, including which specialty they want to take, for example, the patient to. It's like a lot of people don't know probably that allergists do a better job with diseases like asthma compared to pulmonologists, since it's a lung, it goes to the lung doctor. So it ends up going to sometimes these specialties that they are not the most appropriate to manage a condition, because that's kind of a myth out there. So the more caregivers know about few things, about what questions to ask the primary care physicians or the specialists. And for example, what medications that she maybe heard about or read about or knew about that could be detrimental to the elderly person or to the person that they care for, that needs to be discussed. How the condition of the loved person will be improved by taking what? By taking medications, by stopping doing certain things, by changing the behavior in a way, or modifying it. Maybe meals issues, food, nutrition, because some foods interact with some medications. What's the role of like complementary and alternative medicine in terms of taking care of the loved ones? So when you think about the gamut of like care management, of understanding what gaps in the systems we have, we need to be able to provide these tools to the caregiver in order for the caregiver to be able to use these tools in their visits with the member, with the patient, and the physician.
Right. Because it'll be the caregiver at home who is dealing with the symptoms or the results of a change in medication, for example. So they need to receive training. Have you seen a shift in your industry with providing not just the patient but the caregiver with a sort of a discharge instruction leaving the hospital, or at-home instructions for ongoing medical care? Is it going that direction?
It's a hit or miss. It depends on the facility, but right now, because a lot of Medicare penalties are related to readmissions,
right.
Whether it's to a skilled nursing facility or to an acute care hospital, the facilities themselves have now a skin in the game, because before they didn't. It's good to admit more and good to treat more.
Right.
So what's happening in the system as a system, that sometimes, care managers ended up being like nurses, that they are removed, that they are not really the caregivers, but they try to fill in some of these gaps. But I don't think I see like a huge shift to the extent that during discharge, somebody is telling the caregivers about things like warning symptoms once the patient goes home. If they have this symptom in the middle of the night, what to do?
Right.
Do you need to give them an extra dose of medicine? Do you need to call the emergency room or call the physician? Do you need to just drive them and take them there? Do you need to call 911? Depending on the situation. I don't think we do a very good job training the caregivers on these kind of issues. And I think, as I said in the beginning, I think there are a lot of companies that fill these gaps with clinical nurses. Well, however, these clinical nurses are still removed from where the patient is, and they're not close to the patient. Right. They don't know the patient very well. There's a lot of things in relationship to like calling them and even somebody answering the phone. So sometimes these plans are established with a professional case manager or care manager.
Right.
But I think caregivers sometimes should be the first, like I would say, line of defense when these things happening. And when we use them that way, it's going to be for the benefit of the patient. It will be for the benefit of the system. Because without that, people are sometimes going to present with far more grave consequences to something that they could have been taken care of in the house, in the ALF, wherever the person is, compared to just drive them to the emergency room. And when you go to the emergency room by chance,
right.
It's a flip of a coin to get admitted. And then you
Right.
get admitted, and you might have one disease or one symptom you're admitted with, but now you get pneumonia and flu and a bunch of other bad bugs in the hospital. So actually, you're worse off.
Yes, and that's so true. And every time a hospital readmission occurs, recovery decreases. And so we want to prevent hospital readmissions for people. We don't want people using the emergency room unnecessarily. And there, with a little bit of education and instruction, somebody could identify dehydration, which it can be critical, if it goes too far. And it's so preventable if you have the right care in place. And you know what to look for. So I agree with you. So how do we, as family caregivers, providing this sort of backbone, how do we establish good relationships with our medical providers to help us be better advocates?
I think before the visit, caregivers need to be prepared for, either knowing what the visit is for first, is it a routine visit, it's an urgent visit, it's why they're taking the patient to the doctor or to the facility they're going to. So that's one. So you know the reason for the visit, and as a result, you prepare for this visit to be conducive of the outcomes you want it to produce to you, right? Mm-hmm. So what happens is a lot of people go and they just take a back seat and don't participate in the conversation. And they need to be ready also to tell the doctor, ask the doctors all the questions. So maybe prepare a list of questions that they want to inquire about. And just follow these things like a script while you are in the office, so you're not going to sit there and either take a passive role or you're not prepared. So the conversations or the thing goes into too many different directions that you remember later on about them and try to reach the doctor and you can't. So because doctors are very busy people,
yes.
So if you don't use your time in the best way while you are in the office by this preparation, write the questions, not only just memorize them. Probably the best thing is write them down on a piece of paper. Write them in an easy way that for you to explain to the physician as a caregiver. And then, ask them what you think you should do in certain circumstances when things happen. I think most people are used to the fact that physicians know better.
Yes.
And therefore, they don't want to get in the domain of the physician. They feel that we're just going to be listening to what the physician is going to tell us and keep doing it.
Yes, deference.
Yeah, it's that authority figure. That
Yes.
They think that because you've been to the doctors have been to the school. Same thing with clergy, and it's that mindset that authority knows.
Yes,
but
absolutely.
authority can only know more by the sharing of the information, and that's why it's so critical to have that comfort zone to be able to share the knowledge that the caregiver has, because the fact of the matter is the caregiver spends more time with their care partner, their caree, the person that they're taking care of, however you want to explain it, more so than anybody else. And I would imagine from the physician side, I guess the analogy is, your best customer is an informed customer, and if your best patient would be an informed patient or a caregiver that is sharing detailed information with you, so that you could make a more accurate diagnosis and help that family caregiver and their patient.
Absolutely, and I think the point you just touched on, the informed decision-making process,
Yes.
whether it's informed on the behalf of the patient or by the caregiver, or it's informed decision-making of the physician. Mm-hmm. Both of them are so important, because if a physician doesn't have a lot of inputs from a lot of people about what to look for, what's happening at home. Mm-hmm. They see the patient in a 10-15 minute
Right.
time. That doesn't reflect everything about the patient. Mm-hmm. So as a result, people should be able to share this information and prepared to tell the physician, whether it's a PCP or it's a specialist.
Right.
All the information they need, because without these inputs, the decision making would be flawed.
Yes.
I'll give you an example of our caregiving experience. I'm sitting in the doctor's office with my now deceased partner, Richard, and it's been probably 3 3-4 months since we had last seen our primary care physician. And of course, I know what has gone on those last 3 or 4 months, and Richard's sitting there telling the doctor, "Oh my God, I've been eating well, I'm feeling great," and I'm sitting there thinking, "No, wait a minute, I have all these copious notes about really what has transpired over these last 3-4 months," and he's giving the physician a totally different perspective, and I finally had to say, "Wait a minute." And what I'm thinking about here, though, is think of all those folks and the seniors that you deal with who don't have an advocate,
yes,
who don't have somebody to speak for them, and who don't have that person to be able to tell the full story about what's going on. And then you're put in that position to try to gauge really what is happening with this patient.
And I think, Chris, that's a very good point that you just mentioned. First of all, healthcare seeking behavior and talking about stuff changes from one individual to another.
Mm-hmm.
I guess I'd be a very rich guy if I know what drives certain people to do certain things. For example, from my experience, I've seen a lot of people that tend to minimize their symptoms. And a lot of people tend to exaggerate.
Right, yeah.
So if you don't know your patient very well and you know their nature, whether they are minimizers or exaggerators or something, and they don't have anybody with them, the tendency of the physician is obviously he's not going to second guess what the patient's telling him.
Right.
And he's going to take their word, like you said, for granted.
Accept it.
And without having this other voice, this advocate, this extender for them, especially when you put this against like the backdrop of maybe some cognitive issues sometimes, some,
exactly.
Yes.
Some memory issues sometimes.
Mm-hmm.
Yes.
And then most of the older people are very trusting in the system and in the physician and the physician education, and they know better, and they're not going to question anything the physician is asking them to do. Even if the physician has ended up telling them, take this medicine, and give them a script of the same medicine to go and get it, buy it, they're going to take 2 pills of the same medicine and have this happening to some patients.
Oh, it's that authority figure.
Absolutely.
Mm-hmm.
Misadministration and mismanagement of medication, and then you have the caregiver at home with the box, the Monday to Friday box, and you're dosing medication, and you're the one who's also parceling it out. There's so much room for error and breakdown there. And I love the takeaway of this, that medical care is collaborative. It shouldn't be a passive thing. It shouldn't be something that is happening to you. And it's not in a questioning, pushing back on someone who is an expert in what they do. And they are the person with the most knowledge in the room of how to treat. But when all of the pieces are together, the outcome may be better than without the conversation and without the communication. And, something you just said brought back a memory I had really stuffed or forgotten, which was that my mother had a brain radiation. She was never the same. And she was so heavily medicated, but I think it was the radiation impacted her cognition. And so she would tell me things, and I would just accept them because, you want to talk about deference. I was very deferential to my mother, especially in such a vulnerable time for her where I knew our time together was limited. Yes, cookie, like whatever you say, I love you, And she had a PhD, so she had, when she said things were a certain way, I'm going to listen. And I'm going to say yes. But then she would have conversations with others. She would report, for example, to her oncologist that she was eating fine. And I'm looking at her going, I can't get 4 ounces in you. So no, no, you're not. And you're so weak that I have to do your transport in the bed. I have to roll you and all of that. This is not sustainable. You're not fine. And I was that other piece, for her. And I think the collaborative part of this conversation is such a big takeaway, and there's so much that we could cover.
Oh goodness, we could do a whole series on this topic,
Yeah.
and I think we should.
Yes.
I really do think we.
I can tell you just a very unusual case that from a caregiver who happened to be a nurse, and she brought me her dad one day, just for something that wasn't a big deal. It was like, just he had the runs, and she was like, bring him over, and I checked him and didn't find any reason. So I thought it's like, had like a flu and had a viral, and he was in his late 60s, but cognitively he wasn't like 100% at that point. I haven't seen him before. So she told me a story that kind of piqued my attention. The story was that her dad, a few weeks ago, he used to walk walk into the wall rather than walking straight.
Yep.
But he wasn't doing it at the time of the visit. So his examination was normal for me. But because I know her and I know that she's telling me the truth, as a doctor, nurse, caregiver, everything else, I sent him for a scan, a brain scan. And the results were amazing. Golf ball size kind of aneurysm that was on and off pressing on some vital structures and resulted in him losing his balance and walking into the walls. So we sent him for an immediate surgery because it was a pretty big size, could rupture any time. He got surgery like in 2 days. No sequelae, no everything. But if I didn't think about her story, I didn't take it into consideration, he would have been dead like in a few days.
Wow.
Powerful.
Wow.
Powerful. Because this is not meant in jest, but there's no story left untold. And stories, and it comes back to why we do these. It's the stories that connect. And when you could read all the numbers, you can get all the tests. But if you hadn't listened to her, you hadn't listened to her. None of the things on the test would have made any difference.
I agree.
Doctor, I appreciate you coming in today. And
thank you.
Yes, Dr. Ahmed, thank you so much.
So tell our listeners how they can find you, or your contact information.
I work, as I said, for a company called WellMed, and they can either call WellMed or have my email, and which is oahmed@wellmed.net, and they can get in touch with me through that, and they can ask me questions, and we'll be happy to assist them in any way.
That's wellmedhealthcare.com.
Yes.
Okay, it's great having you today.
Thank you.
Thank you so much.
Amanda, you're getting better guests than I am getting.
Well, I'm one of your guests, so I take exception to that.
That was the response I was looking for.
That was the setup. But no, this is wonderful to have people like Dr. Ahmed and the consumer debt attorney, my husband, and the financial planner, Christina, to come in and share their knowledge with us.
Because it's about having conversations about care.
And
candid conversations about care.
Communicating effectively.
Okay, so we're coming. We've just finished our 5th. Next week we're gonna wrap it up next week, and we're gonna talk about advocacy. That's going to tie this whole 6 series together. And I just can't say thank you enough for doing this. This has just been terrific.
No, I feel the same way, and I look forward to wrapping up and hope that this has been
and we'll do some more. I think we're going to get Dr. Ahmed and do a series. The three of us should do a series together.
That's a great idea.
I think that's a great idea.
Okay. We just voluntold you.
We just voluntold you. That's right. I think he knows that. Okay. Well, that does it for this episode of Healing Ties. Next week we'll be back for our final. Well, maybe I shouldn't say final. I think it's just going to be the end of our 6th series. I have a sense we're going to be doing a little bit more work here on our Candid Conversations About Care. I'm Chris McClellan, the Bowtie Guy. I'm creating a life to love after caregiving ends through radio, writing, travel, advocacy, and being with awesome people like Amanda and Dr. Ahmed. Healing Ties is a part of the Whole Care Network. Check us out online at wholecarenetwork.com. We'll see you for another episode real soon. Bye-bye.